How is it coming? It's okay.
Okay, this is Dr. Gnanaraj doing rural urology bladder pressure studies, take 2.
We are going to talk about urodynamic studies or cystometrogram or common English bladder pressure studies. When I was a student of urology, our institution CMC got the first urodynamic machine. And what it did was it measured the pressure inside the bladder through an infant feeding tube which we passed into the bladder and then connected to a pressure transducer. But then this pressure which is measured inside the bladder is the addition of the detrusor pressure of the bladder muscle which contracts and generates the pressure and the abdominal pressure. So, to measure the abdominal pressure, we had to put a catheter and the balloon in the rectum, and that is connected to another pressure transducer. And we had a computer which subtracted these two pressures and give a graphic display of the actual pressures during the entire process of voiding. The normal process of voiding takes about 3-4 hours. So, what we had another infant feeding tube to fill the bladder to sort of expedite the process of passing urine. But these are not the normal circumstances, so the interpretation had to be cautious. But this is a very expensive way of doing it. So, what we do nowadays is a very simple way of measuring the bladder pressures. So, what we do is we pass 2 infant feeding tubes. Of course, it has to be sterile. We pass it into the bladder and we use a normal IV set. So, we use one of the infant feeding tubes to fill the bladder using IV set and the other one to measure the bladder pressures. So, this is connected to a ordinary inch tape and the 0 is kept at the level of the pubic symphysis. Then you can see the when the bladder has urine, you can see the urine gets filled up here. I can see a fluid level here that indicates the pressure inside the bladder. And of course, it is a combination of the pressure inside the bladder and the abdominal pressure. So, we use our brain to interpret what is happening in the abdomen. So, it is good to have a hand on the abdominal wall, so that you know when the patient is contracting the abdominal muscles and the pressure increases. So, this procedure what we in short call CMG is carried out for evaluating the lower urinary tract symptoms, to give you an idea what exactly is happening, so that you can objectively evaluate what is the problem. So, the commonest use, as I described about the symptoms, is quantify the level of obstruction in bladder outflow obstruction. If there is a prostate enlargement, to find out if it is significantly causing obstruction or not, we need to do a cystogram. If there is a neurovesical dysfunction or the nerves to the bladder not acting properly, then we need to do the cystometrogram. You need to remember that almost 1/3 of the spinal cord nerves supply the bladder. And then you have to realize that it is almost like a proper surgical procedures, because you are passing things inside the body, inside the bladder. So, you need to clean and drape as for any surgical procedure. You need to have sterile infant feeding tubes, 2 sterile IV sets, and then you have this setup ready where you have the inch tape to measure the bladder pressures in centimeters. And in many of the rural areas, we prefer to give a prophylactic antibiotic also. So, how do we do it? So, first we ask the patient to empty the bladder and come, and then after we are cleaned and draped, we use jelly to lubricate and also hold the infant feeding tubes together. Then we slowly pass the infant feeding tube centimeter by centimeter, and usually there is not much of a problem, especially if you in men, if you make the curve simple curve by lifting the penis up, and there may be resistance when you reach the level of the sphincter. So, there you have to remember that even a soft infant feeding tube, if we keep poking it, it can cause injury and later stricture. So, we have to be very, very gentle in passing the thing, and if there is an obstruction, you apply gentle pressure and keep holding in that place, because very often they voluntarily contract, and there is a time when they relax. They can't keep on contracting for a long time. When they relax, it goes in, and once it goes into the bladder, then you can see the urine coming out, and both the infant feeding tubes are filled. So, once it's filled, you connect one of them to the manometer to measure the pressures, and the other to the IV set, so that somebody looks at and keeps filling and noting down how much volume is gone in. And then you need to ask the patient a couple of questions. So, when they start feeling that there is some urine in the bladder, and when they have the normal sensation or desire to pass urine, and then you ask them to hold on for some more time, so that they have the urgency. And then if they can't hold anymore, when they want to pass urine, you ask them to pass urine and measure the maximum voiding pressure. Then once they finish voiding, then you disconnect all the tubes and measure how much post void residue is there. So, you measure the sensations, you measure the pressures, and also you should actively look for what is called unstable contractions or uninhibited detrusor contractions. So, if the detrusor muscles are hyperactive, when the bladder is the sphincter is closed, it will contract. So, the pressure will go up and then start coming down, and the same thing will happen if somebody is coughing. But the difference is that when you are coughing or straining the abdomen, it goes up quite rapidly and comes down quite rapidly. On the other hand, if it is due to unstable contraction, it goes up slowly and comes down slowly. You also note if there is any leak in the leak of urine during the procedure. And if you turn to your right and look at the PowerPoint, you can have a simple form to record the pressures. So, how does a normal cystometrogram look? So, as soon as you pass the catheter, normally there should not be any significant post void residue. So, if at all there is, it should be less than 30 ml, and the resting pressure is about 8 to 10 centimeters of water. And God has created the bladder in such a way that when it fills up to the capacity, say from 50 ml to 350 ml, there is hardly any change or increase in the bladder pressure. This is unlike a balloon. If you are inflating a balloon, as it expands, the pressure inside increases. But the muscle fibers in the bladder are arranged in such a way that this does not happen. And then when you reach the stage where you want to pass urine, there is a slight increase in pressure, which sends the information to the brain that you need to pass urine. Then when it is convenient, when there is a available toilet and it is empty and you are gone in, then the brain sends impulses to the sphincter to relax and the bladder to start contracting. And normally the maximum voiding pressure, it's the pressures when you are voiding is in a bell shaped curve, and normal pressure is about 60 centimeters of water in men and 40 centimeters of water in women. And as I have been mentioning earlier, there should not be any significant post-void residue. Up to 30 ml is acceptable. And there are obviously, of course, no unstable or uninhibited detrusor contractions. So, this is a normal systometrogram. Now, we go and have a look at some of the abnormal ones. The most common, as I said, is the bladder outflow obstruction due to benign prostatic hyperplasia. So, as the prostate keeps enlarging, it can cause obstruction. And the prostate has both glandular tissue and also fibromuscular tissue. So, the size of the prostate does not really mean that it is causing obstruction. Sometimes you can have a larger prostate which does not cause obstruction, or a small prostate which can cause significant obstruction. That is the reason why the systometrogram will help, because it will tell you the accurate pressure. So, if the pressure is 60, it is normal. If it is between 60 to 90 centimeters of water, is a progressive obstruction, and these are possible for treatment with medication. But once it reaches more than 90 or 100, then the chances of the patient going into acute painful retention is very high. So, that is a stage where you sort of recommend them for surgery. And also, when there is a MAP is high, you should be aware that there could be a significant post-void residue. And sometimes there is a deficiency of the bladder sensations. For example, if it's diabetes, the sensations of the bladder are not there. So, the bladder can distend almost 1.5 liters without the patient realizing that he has a full bladder. And then again, if there is a injury to the spinal cord, if the neurovesical dysfunction, the sensations are affected or altered, and that is the reason why you should look whether the patient has normal sensations or not. And then also we look at what is called the compliance of the bladder, which is another name for elasticity of the bladder. Normal bladder, as it expands from say 50 to 350 ml, there is hardly any increase in pressure. But if the bladder wall is thick, then the pressure increases, it acts more like a balloon. Or if there is this contracted due to diseases like tuberculosis, or there is infection, anything which or edema, anything which causes the muscle to become thickened, the bladder wall, it will cause poor compliance. And then these unstable contractions can occur either because of neurovesical dysfunctions or neurological problems, or even long standing obstruction, where the muscles become hyperactive, and this is a problem because as long as the uretrovesical junction is okay, the pressure does not get transmitted up into the kidney. But if there is a damage, it can also cause damage to the kidney. So, it is very important to find out whether unstable contractions are there or not. And then finally, we need to decide about whether any significant post-void residue is there. If it is more than 30 ml, it is significant, because normally we have some bacteria in the urine, and once you pass urine, all the bacteria come out, even though they may, then you start all over again. Every 20 minutes the bacteria numbers double, and if it goes more than 100,000 per ml, then it causes infection. But if there is a significant post-void residue, each time you start with a higher bacterial count, and because the doubling happens as time goes on, you will reach a stage where there is significant infection. And again, the functional capacity of the bladder also is smaller compared to normal if there is a significant residue. So, these are the things which you look for to exactly see what happens or interpret the various lower urinary tract symptoms. Stop. Okay, next we will start treatment of the